My name is Akshjot Puri. I work at Houston Methodist. I'm a breast medical oncologist, and we'll talk about some key trials in early ER-positive adjuvant setting. So these are my disclosures. Moving on, we'll start with the hottest topic, which is OPTIMA trial. Phase 3, this is a randomized non-inferiority trial looking at chemotherapy in ER-positive, HER2-negative, high-risk patients. So the trial design looks a little bit complicated, but let's walk through it. Women 40 and above were only included, so this is important to note. Less than 40 women were not included in this trial. Women could have 0 to 9 lymph nodes, so this is again important. N2 disease was included in this trial. So patients were randomized to the control arm, and they got chemotherapy regardless of any score. They were just going to get chemo and subsequently endocrine therapy. And they also got the Prosigna test after they completed their treatment. And then we have the test-directed arm. The Prosigna was done up front. So if the score was high, which is ROR less than 60, they got chemotherapy and subsequently endocrine therapy. But if the score was less than 60 or 60, that's considered low score, they only got endocrine therapy. So some things to keep in mind, all premenopausal patients got ovarian function suppression. Even if their periods had ceased after chemotherapy, they would still get ovarian suppression. Patients were blinded to their Prosigna score, regardless in whichever arm they were, so this would not impact their adherence and compliance. And the patients who got chemo also were blinded, so they didn't know if they were in the test-directed arm or in the control arm. So the primary outcome was invasive breast cancer-free survival, looking between the control or test arm, and the non-inferiority margin was defined at 3%. And a key secondary outcome, and a study was powered for this, was invasive breast cancer-free survival only in the low-risk group, looking at chemo and endocrine therapy versus endocrine therapy alone. And the non-inferiority margin defined was 3.5%, a little bit higher because these patients generally have lower recurrence. So this is again important. This is not IDFS. Invasive breast cancer-free survival makes sure that we don't dilute it with non-breast cancer events. So looking at the population, about 38% premenopausal women, about 31% grade 3. So just for some context, our exponder had only 9% grade 3, and TAILORx had about 18% grade 3. About 46% patients with 3 centimeter or higher tumors. And this is, again, very important. Most patients in the trial were lymph node positive. 74% were N1, and 18% were N2. And this is the ROR score. We can see both control and test-directed arm. They're very normally distributed. So the study did meet its primary endpoint. The non-inferiority was at 2%. So there was only a 1.5% benefit in the control arm where everybody got chemo versus the test-directed arm where only the high-risk patients got chemo. And this is the secondary endpoint looking at the low-risk population, which also met its endpoint of 2% non-inferiority. So 1.2% benefit favoring chemotherapy than endocrine therapy in the low-risk population. Looking at distant recurrence-free interval, so 0.8% benefit in the control arm where everybody got chemo versus test-directed arm. And then looking at the low-risk patients, only 1% benefit of chemo versus endocrine therapy. And when we divide this by menopausal status, again, very impressive result, 1.3% difference, regardless if you're premenopausal or postmenopausal in the control arm versus test-directed arm. So the graphs are almost overlapping here. So these are some important differences in the genomic assays we have so far. The Oncotype is looking at 16 genes, MammaPrint 70, and Prosigna at 50 genes. So there's not much overlap between these genes. There are only 10 genes that are overlapping between Oncotype and Prosigna, and only 2 genes between MammaPrint and Prosigna. So they are definitely testing different genomic signatures. Proliferation was included in all of these signatures. Pathological tumor size and PAM50 subtype is only part of Prosigna's algorithm. And the reference ranges are 0 to 100 for both Oncotype and Prosigna, but -1 to +1 for MammaPrint, which we all know. And again, looking at all of these historical trials, these are big studies. TAILORx, all lymph node negative population, very long follow-up. MINDACT, about 20% N1, most N0, and RxPonder, all N1. And now we have the OPTIMA trial, way higher risk population, more N2 disease, more grade 3 disease. But we see very consistently in all the trials, the postmenopausal women are looking like they're not getting much chemotherapy benefit across different endpoints. But the premenopausal women, the historical trials showed about a 4 to 6% chemo benefit. And this is really minimized to 1.3% despite the much higher risk OPTIMA population. And a key difference here, 100% women in OPTIMA got ovarian suppression, and less than 20% in previous historical trials, women got ovarian suppression. And we also see a little signal from the RxPonder subset analysis of women less than 55 that the medium and high AMH group, which is reflecting a high ovarian reserve, got better outcomes from chemo and endocrine therapy versus endocrine therapy alone versus the low AMH group. So we've been seeing this signal for a while, but the OPTIMA trial is just proving the importance of ovarian suppression in these groups. So moving on to some limitations. So it is only a 4-year median follow-up. Majority of the patients are in less than 5 years follow-up. The N2 population, even though it makes up 18%, there are only 37 events so far, and about majority of the population is in less than 5 years of follow-up. The presentation did not have the ALND data, but we're hoping the manuscript will have that as well. Some other points, premenopausal less than 40 years were not included. The pivotal trials were done, or the seminal trials were done during like 2010 when soft-in text was just coming out. So there was not a lot of comfort in eliminating women that were younger or doing de-escalation trials in them. Again, 90% of women were Caucasian in OPTIMA trials, so how does this apply to our very diverse patient population? That we will have to find out. And the role of CDK4/6 inhibitors or SERD is not understood. Despite having advanced nodal disease, only 6% of patients had CDK4/6 inhibitor in the trial. So we do have some ongoing trials. We have the OFFSET trial, which is looking at young women and Oncotype less than 25. They would be randomized to chemo versus ovarian suppression. We also have the extension of OPTIMA trial, OPTIMA Young, looking at younger women. Same clinical trial design. And then we have for postmenopausal women, RX-Fine Low. So they're very advanced disease, T3 or more, N2 or more, Oncotype less than 25, and we're looking at, or the investigators are looking at, if there is any benefit of chemotherapy. So there's chemo, AI, and ribociclib in one group versus just AI and ribociclib in the other group. Moving on to another very important trial, lidERA, which looked at Giredestrant versus standard of care endocrine therapy in adjuvant treatment for ER-positive, HER2-negative breast cancer. So we are all very familiar. Giredestrant is a new generation SERD, which causes ligand-dependent and both independent antagonism of ER receptor and subsequent degradation. Previous smaller studies like COOPERA and EMPRESS showed that the Ki-67 decrease is more impactful with Giredestrant than anastrozole and tamoxifen. So this led to the design of phase 3 lidERA trial, where stage 1 to 3 patients were included. But to note, these are all higher risk patients. These are not the common T1 and 0 low-grade patients. So if they were more than 1 centimeter, they had to be grade 3, high Ki-67, high genomic risk score, or had a positive lymph node. So we're focusing on a high-risk early-stage population. About a little over 4,000 patients were randomized to Giredestrant daily versus standard of care endocrine therapy, which could be tamoxifen or AI, and these were given for 5 years. And premenopausal women got ovarian suppression. The primary endpoint was IDFS. So looking at the patient population, about 60% women were postmenopausal, 60% Caucasian. Most women had advanced disease, stage 2 and 3. Most women had lymph node positive disease. And most women had high or medium genomic risk score. 80% got chemotherapy, and 84% got AI in the SOC group. So again, looking at the high-risk population that was included in this trial. The study did meet its primary endpoint of IDFS with a hazard ratio of 0.70. The study has been followed for a little less than 3 years now, and it has 77% events, so about a 30% or death at even less than 3-year mark, which is very impressive for an early-stage ER-positive study to show. So this is the distant recurrence-free interval, again showing nice separation with Giredestrant being better. And overall survival is immature, but again, Giredestrant looks like it is outperforming SOC endocrine therapy at this point. Looking at the treatment side effects, the treatment duration, dose intensities, even grade 3 to 4 adverse events were not much different between the two groups. There were no fatalities in the Giredestrant arm. But most importantly, the discontinuation rate was lower in Giredestrant when compared to SOC. And also fewer patients switched to alternative endocrine therapies in Giredestrant versus SOC, 5.7 versus 10.1%. When we look at the tornado plots, the most common grade 3-4 adverse events, as we would imagine, are arthralgias, and then there were some hypertensive events. And this is similar regardless of menopausal status. And like I said, the discontinuation rate for musculoskeletal events and vasomotor symptoms was lower than standard of care endocrine therapy. And grade 1 and 2 bradycardias were seen, not any grade 3 or 4, and venothrombotic mulling events were lower in grade 3 and 4 were lower in Giredestrant versus SOC. We're breaking down IDFS by menopausal status. We again see, regardless of menopausal status, Giredestrant is outperforming standard of care endocrine therapy in both premenopausal and postmenopausal women. And treatment discontinuation because of musculoskeletal side effects are also lower in Giredestrant versus endocrine therapy in both groups. So this is a very historical trial. After 30 years, we have an adjuvant endocrine therapy that has proven an IDFS benefit. There are still some unanswered questions. We want to know how the PROs and the adherence data evolves as the study matures. It also looks that the ESR1 mutation does not really matter in the early stage. We've seen this with immunotherapy also, where in the early stage, everybody gets benefit, not in the metastatic setting. So the oral SERDs have about 100% more affinity for ER receptors than tamoxifen, and also they work ligand-dependent or independent, versus AI can only decrease the ligand. And so that's why the early stage, it just is a better anti-estrogen, and we also saw lower discontinuation rate. So that could be some of the reasons why we're seeing the differences in the study. Once the receptor has an ESR1 mutation, the stored SERD still has a capability of attaching itself to the helix 12 structure, and that is better than tamoxifen, and that's why it still works in the ESR1 mutation. We don't know how we integrate CDK4/6 inhibitors because this trial did not allow that, and we don't know what about extended duration of SERDs. Is that helpful? We don't have an answer to that. And we also don't know data on other adverse events that are important for discussions with patients like cardiac disease, bone loss, sexual health, and mental health. So there are some ongoing studies that will shed light on this. We have another initial SERD therapy trial, Cambria-2, that does allow abemaciclib. And we have a group of other trials that are looking at endocrine therapy for 2 to 5 years. And then after that, we do a SERD. And some of these do allow CDK4/6 inhibitor as well. So more to come. And finally, we'll move to NATALEE and monarchE trials. So on the left, we have NATALEE, where the strategy for patient selection was stage 2 or stage 3 disease. If somebody had stage 2A and 0, they needed to have higher risk features like grade 2 Ki-67 more than 20% or a high Oncotype score, or anybody N1 would be included, or 2B and beyond. About a little over 5,000 patients were randomized to ribo, 400 milligram for 3 years with an AI versus AI alone. Tamoxifen was not allowed because of the QTc prolongation risk with ribo. And the primary endpoint was IDFS. The study was only powered for this. So in contrast, when we look at monarchE on the right, the strategy here was to focus on heavy disease nodal burden, so N2 or more, or N1 if they had grade 3 or 5 centimeter or greater was included. Again, about 5,600 patients randomized to abema 150 for 2 years with an AI or tamoxifen, or AI or tamoxifen. The primary endpoint was IDFS, and a key secondary endpoint was overall survival. So the study was powered for both of these. And this is again to allude that there's a lot of intermediate risk population like T2, T3, T4, and 0, or even a T2 and 1 that would have not qualified for monarchE but would have qualified for NATALEE. And no discussion is complete without looking at the actual patients that made these trials. So about 44% patients premenopausal in both trials, and about half of them got ovarian suppression in both trials. 100% patients got AI in NATALEE, 70% monarchE. And this is very important. 19% patients with N2 or 3 disease in NATALEE versus 60% in monarchE. N1 was very comparable, 41% or 40%. And then again, this is important, 28% N0 disease in NATALEE versus 0.2% in monarchE. Grade 3s were higher in monarchE. Chemotherapy was higher in monarchE. So it's really reinforcing how much high-risk population monarchE included. Looking at primary endpoint of IDFS, both studies met their primary endpoint. NATALEE's been now followed for about 5 years, and monarchE a little over 6 years. The hazards ratio are not very different, 0.716 for NATALEE and 0.734 for monarchE. The number needed to treat is 15 for monarchE, so we need to treat 15 patients to prevent one recurrence, versus NATALEE is 22, again showing the higher risk population included in monarchE. And this is an important update with overall survival. So it is very important that a trial with early stage breast cancer at less than 7-year mark shows an overall survival benefit. And the trial did meet its secondary outcome, which is overall survival, with a hazard ratio of 0.84, so about a 15% reduction in death with a delta 1.8. In contrast, looking at NATALEE, so to remember, the study was not powered for this, and also this is a 5-year follow-up, so it's shorter. There is a numerical advantage with ribociclib, the delta 1.6. The hazard ratio is 0.8, and the confidence interval does cross 1. Distant recurrence-free interval was again improved in both the trials with the CDK4/6 when compared to endocrine therapy. Discontinuation rate, almost 40% for ribociclib and NATALEE, and 20% were because of adverse events, most commonly being LFT elevation and arthralgias, versus abemaciclib, lower discontinuation rate, 26%. And as we recall, abemaciclib is also for a shorter duration, 2 years. Discontinuation was because of AEs in about 16% patients, most commonly being diarrhea and fatigue, as we're all very familiar. So this is to point out that there are a lot of patients that were included in NATALEE that are still doing really well. So if we look at the control arm in stage 2, node negatives greater than 40, they still are having a pretty decent outcome, even in the control arm. So can we truly identify high-risk groups to optimize this risk-benefit ratio for CDK4/6 inhibitor? What about these intermediate-risk patients? Are there other options that maybe are not as toxic as a CDK4/6, but better than just AI? What about increasing use of ovarian suppression in premenopausal women who qualify for a CDK4/6 inhibitor? I mean, in both the trials, only about half of the women that were premenopausal got ovarian suppression. We definitely need biomarkers. We saw at ASCO that NATALEE data showed that both luminal A and B benefited with ribo. The numbers for basal and HER2 enriched were very small to make any conclusion. We also saw some gene expression nanostring analysis from NATALEE that showed that there are some genes that do predict higher CDK4/6 benefit. Again, but we're nowhere close to making clinical decisions based off on this in clinic yet. And monarchE has also shown some nice data with ctDNA persistence being more prognostic, poorly prognostic, and ctDNA clearance being better. So the Signal ER101 study is looking at it a little bit further, with patients who are ctDNA negative will only get endocrine therapy, but once they have an emergence of positive ctDNA, they would get CDK4/6 inhibitor. So Giredestrant is under priority review and is expected to get approved by end of this year to add to all this confusion. So what I would like to summarize or say for now is that if we have a high-risk patient who does qualify for monarchE over to the right, that patient should get AI, ovarian suppression if they're premenopausal, and definitely a CDK4/6 inhibitor, preferably abemaciclib at that point, because that's the only trial with overall survival benefit. And chemotherapy would likely be applicable to a lot of those patients, but that might change with the OPTIMA trial. And over to the left, we have very low-risk patients that are T1 and 0s, grade 1, and they should probably just get TAM or AI. And everyone in between, ovarian suppression and SERD may be a good consideration. And ongoing trials will help fine-tune this further. I will close with this patient case. So I saw this 49-year-old lady who's premenopausal. She palpated a left breast mass, about 2.3 centimeter, and IDC, ERPR positive, HER2 negative, low Ki67. She has a lumpectomy, 3-centimeter tumor, grade 1. 1 out of 2 lymph nodes are positive. 3 millimeter, no extranodal extension. Her Oncotype is 5. So she got 6 cycles of TC, she got radiation, she got BSO. She's been having a lot of difficulties tolerating AI because of arthralgias, and she could not do ribociclib because of LFT elevation. So I would like to leave you with some thoughts and to think about this in the future. Did this patient really need chemotherapy? Now with the OPTIMA trial, a lot of these patients may be able to omit chemo. Did she really need CDK4/6 inhibitor, or could we do better with other drugs that have less side side effects. And what I would propose is maybe in the future, a patient like that could go to surgery, radiation, and possibly just ovarian suppression and SERD. Thank you.
Fantastic.
Look at the baton.
Thank you so much. Very good presentation. So please, right now we have like about 5 minutes Q&A session for this presentation. So if you have any questions, I'll start with one question. Based on the OPTIMA, if the Prosigna is available to you today, would it be complementary to other genomic tests like the Oncotype or the MammaPrint, or do you think it will replace them?
Yeah, it's a great question. If I could order all 3 of them, I would. I don't think any insurance would like me. Everybody would fire me. So I think right now we might see a lot of overlap. A lot of people may order an Oncotype and be like, oh, I don't like this number. Let's just do a Prosigna. And I actually saw some initial OPTIMA data from like the early trials that laid the base of this trial. And it showed the overlapping numbers between Oncotype and Prosigna. And it looked like people who had low Prosigna and high Oncotype still had a better prognosis, versus people who had low Oncotype and high Prosigna had a poor prognosis. So it seems like Prosigna is a little bit more comprehensive than Oncotype, and it could replace Oncotype in the future. But I think right now people might be juggling, and I'm very sure with the company being new, it might not be a bounce bill to the patient and might be okay, but going forward, we may have to make up our mind with one drug or one test.
Any question from the audience? Yeah, go ahead. Yeah, please.
So we have an issue in that we often get an outside MammaPrint ordered by surgeons for node-negative disease, and then it's not the best evidence for...
No, you're mic'd already. They're going to turn it on. Don't worry. Yeah.
Sure. And then, so it's not the best evidence, and then we end up ordering an Oncotype, and they're discordant, and that's very problematic. And I've had patients who show up and say, my surgeon's office just called me and said, congratulations, your MammaPrint is low risk, so you don't need chemotherapy. And then I ordered the Oncotype, and it's high risk, and that's very problematic.
That's the problem.
And then, so that's one issue that I'd love to resolve as a community. And then number 2, for this patient that you describe, would you do an AMH to decide about chemotherapy given what we've seen from our responder?
Yes, thank you, Dr. McArthur. Great practical questions. In her case, I did not use AMH because the standard of care as per our responder at the time, patients were going to get benefit with chemotherapy, and she did resume her menses, so ovarian suppression or oophorectomy made sense for her. I would say that going forward, we have a lot of data saying that ovarian suppression is the better way to go instead of chemotherapy, and any of these controversial patients should likely get enrolled in the offset trial. But I've had patients who have not wanted to enroll because of the randomization leading to chemotherapy and have just chosen to go to ovarian suppression. And I think in a patient like that, the AMH would be a great guiding factor, because if they do have lower AMH, then it's a little bit easier decision to not go on the trial and just possibly consider endocrine therapy. And in terms of like the discrepancy, I do think we're going to see more and more of it, as now we have 3 genomic assays. There's still people who use MammaPrint, and now with Prosigna coming out, we don't even know what the overlap between MammaPrint and Prosigna is going to look like. So I think it's more of a discussion with the patient and seeing what the data is out there. The OPTIMA is one of the most modern trials, considering the high-risk population there. So I think it's more counseling for the patient, but we're definitely seeing multiple tests being ordered. Yeah.
Fantastic. Any other questions? Yep.
Okay. Very simple question. You mentioned MammaPrint. I'm very interested in the blueprint component versus the BAM50 component that's reported by ROR, reported by the Prosigna. Because I think that this is underlying consensus, or probably can be an underlying biology that unifies a lot of those. The MBI score itself and the RR score are arbitrarily chosen, but the blueprint and the BAM50 tend to have a little bit of an anchoring. Now, I wonder, if this can be something that hopefully we can learn, probably also essentially into the metastatic setting. There's been a lot of work trying to understand, why are we not actually doing the luminal A, luminal B distinction in the metastatic setting, and characterizing these different. Do you think that this is something that might be studied at some point? Because I think that this is really a big issue with these two assays.
So if I understand your question correctly, it's the blueprint and the MammaPrint also has the PAM50 signature?
Well, the blueprint is an 80 gene classifier, different from the 70 genes on the MammaPrint itself, and then the blueprint gives you the luminal A, luminal B, right, HER2 enriched, and basal. But these are not based on the same 50 genes with the PAM50. However, there is a pretty strong concordance actually published there already. So the Prosigna, we know that this is the PAM50 classic, Chuck Beru's PAM50. So I think that there is a concordance in that biology,
right.
And I think that this is something that we probably need to address a little bit more when it comes to some of these genomic assays.
Yeah, I think it's really important to understand where are these tests coming from? Like, what are they studying? Like, the Oncotype is based off on NSABP20 and looking at that genomic assay, versus MammaPrint is based on historically, like, looking at basically with not artificial intelligence, but basically with data sciences, that what are the genes historically in all trials that were 6 pathways that were higher risk. So it's very, very broad, versus now PAM50 is in the OPTIMA and becomes the pivotal pathway for that. And it's also interesting that the Prosigna score changes when you put in the tumor size has changed and the lymph node number has changed too. So that is also something that the other tests don't incorporate. And this is something that is a little bit more genomic, clinical altogether, and you're not guessing the RS-Clin score. So definitely, I think we will see how people are using it more. I've definitely ordered a few, have not had any results yet, 0. It's a little bit time, I think, until all the forums and portals work.
All right, Dr. Remawi has a comment, and then we'll move on to the next.
Well, when I tried to explain how signatures work to myself, nobody has the overall picture. Signatures are a way to look at different parts of the tumor and try and discern more about it. So the equivalent of like saying we're going to look at people's eyes, fingers, and toes. Some signature looks at the toes, and from the toes they can tell us apart. Some signatures look at the fingers, and from the fingers they tell us apart. And the third looks at the eyes. They look at completely different things, or minimally overlapping, and they are discordant enough of the time, and they're all accurate enough of the time that you cannot say one is better than the other. It's just how they were studied. So yeah, could one have more comprehensive view versus less? Yes, but no signature has the overall picture. And I think each of those signatures has the advantages and disadvantages, or the strengths and the weaknesses of the trial that studied them, more than it is actually an enhanced performance.
Do we need new signatures, though? Are we already, I pointed out the discordance between MammaPrint and
That will be a fantastic question to do at the end when we do the Q&A. All right.